You can remember everything in medical school, and it will take less time than you're spending studying at the moment. I know this because I've gone from struggling to keep up to getting high distinctions multiple years in a row and winning an award in medical school. The crazy thing though is that since I've started studying like this, I've been less stressed and I've enjoyed my life more. So in this video, I'll share with you the problem that's making you forget everything you've learned, how you can study to remember forever, and actually show you how to do it live. But before that, I think we should talk about whether you should even be trying to remember everything in the first place. The thing is, it's not actually possible to remember everything in med school, and that shouldn't be the goal. One of my favorite academics in faculty reminds us all the time that patients don't remember how much a doctor knows, but how a doctor makes them feel. And that's what's truly important. But I will say that having confidence in your knowledge, what you do and do not know, actually helps you have the confidence to talk to patients better, to communicate to them better, and to explain things in a way that they can understand, which does actually help you become a better doctor. So it's not possible to remember everything, but it is possible to remember everything you need to know in such a way that it allows you to explain things to patients well, gives you the confidence to ask questions and to speak up, and that's what allows you to do well on your exams. So now let's start with the problem with remembering, which isn't actually to do with you, but with your brain. Not your brain in particular, but the human brain. You see, learning is a lot like filling a bucket, but it has a bunch of holes in it. What this means is that when you learn something, it immediately starts leaving your mind. This is seen in the forgetting curve, which I'm sure you might have seen. But there's an issue with the way people try to fix this problem of forgetting. Most people focus on active recall and spaced repetition, which is like catching the liquid that's leaking out of the bucket and pouring it back into the bucket until it stops leaking out as fast. There is evidence behind this, but it doesn't actually deal with the problem in the bucket, which are the holes. If the holes in your bucket are massive, then you'll have to keep refilling the bucket so often that it's exhausting and you'll feel like you're not learning anything. I know from experience that doing stuff like Anki and flashcards is really draining for this reason, because you're constantly getting stuff wrong and having to redo flashcards that you just did. The secret to remembering everything in medical school is to deal with the holes in the bucket. This is done by something called encoding, which is basically like patching up the holes in the bucket. It means learning things well the first time so that you actually forget it slower and don't need to do as much active recall and spaced repetition. Learning like this is actually quite enjoyable, and it's made me actually enjoy studying. So how do you go about doing it? Well, there are multiple principles to encoding that are powerful when used together. The first of these is to always learn the easiest possible information first. When you learn any topic, there will be information that you already know about it. What you can do from this is to use your curiosity to guide you as to what you should learn next. For example, I studied shock the other day, and I already knew vaguely about the different types of shock, but I wasn't entirely sure about the differences between them, particularly between distributive and hypovolemic shock. Given that I already knew a general kind of framework to think about it, I started with the next easiest thing, which was learning that difference, and I worked from there. This means that you'll actually approach the topic layers, such that you're always picking the next easiest detail to learn. The second key principle is to use higher order thinking. This means studying more content at once, but comparing and contrasting all of the content as you're learning it. For example, if you were learning about arrhythmias, you wouldn't start by just learning AF in full, then flutter, then SVT. You would learn all of the arrhythmias at once and compare and contrast the differences between them and why those differences and similarity exist. This is because we're usually taught things one condition at a time. So if we try to use higher order thinking to learn conditions one at a time, it's very easy for us to slip into old bad habits and to forget that type of thinking. The third principle is to make information intuitive. Simplifying information and putting it into a form that you can understand more easily is critical to allowing you to remember things forever. For example, you can think about problems that happen in the heart as issues that happen in a pump. You can think of ventricular failure as the pump getting weaker versus stenosis as the exit of the pump being blocked versus arrhythmias as the wiring of the pump going haywire. Having analogies and ways to simplify information makes it much more memorable. And the fourth principle ties into this. It's so often that you'll rock up to an exam and you'll know where information is on your page of notes, but just not what it is. Just like making things intuitive, spacing things out, and using visuals will help you remember content for longer. So now, let me show you how I would go about doing this with a live demonstration. So today I'm going to be studying stroke syndromes because I feel like it's a pretty hard part of the neurosystem that I haven't reviewed in a long time. And the reason that it came up to me was that there was a patient on the ward who had a hemianopia, and I realized that I had kind of forgotten things about the visual pathways and what strokes would cause that. The other thing is that people tell me all the time that you can't really remember details from mind maps, and I'd like to show you that that isn't true. And I think stroke syndromes are a great example of a topic in medicine where there are a lot of details and they're kind of hard to remember intuitively, but I'll show you how in this mind map. To study today, I'll be using Amboss as my main kind of primary source of information. And for any questions, I'll go to ChatGPT or Google for images or YouTube videos and things like that. And I'm just going to be writing my keywords on the side in RemNote. And the mind mapping app that I'm using is called Harmony. So to start, I'm going to create a list of keywords from this Amboss article because I want to remind myself to keep looking at the bigger picture and not to just like hone in on one single topic and just learn about that. So I want to learn about everything at once, which is about creating that bigger picture. Okay, so I have this list. This didn't take me long to write, just of the different basically subtitles of each of the table columns. And the only things I didn't really include were the lacunar syndromes because I felt that they were all kind of similar not similar, but they all came under this idea of lacunar syndromes. So I wanted to just keep that as its own, just to avoid having too many keywords at the start. So now to start, I just want to think about all of these different stroke syndromes together. And I'm just going to start with literally one of them, and probably the one that I know the most about, which are the main three, MCA, ACA, and PCA strokes, and just think about how they might be different from some of the other ones on the list. So just to start with the MCA stroke, I'm having a look at that. And the thing that it says here about the clinical features is that it's weakness and sensory loss more in the upper limbs and lower half of the face than the lower limbs. And I'm just thinking a little bit about that and why that might be important. I'm thinking about whether it might be a differentiating feature, which I know that it kind of is. But I also know that a lot of the other strokes also have weakness. So I'm just trying to think maybe a little bit about how I can differentiate an MCA stroke from perhaps some of the other ones that I don't really know that much about that might also have weakness. But for now, I'm just going to kind of make my life easier and just write something to help me understand that part a little bit more. Now, I want to kind of compare this to a stroke syndrome that I maybe don't know that much about. So I might think maybe about one of the medullary syndromes instead. So I'll just search up one of those, medial medullary. So medial medullary syndrome, and I'll see what kind of happens here. So reading about medial medullary syndrome, I see that it talks a little bit about the affected vessel, the affected structures, and the resulting symptom. And it can see that it also affects the face, also causes hemiparesis and some differences in proprioception. So there are some symptoms that kind of seem to overlap a little bit, which means that maybe I shouldn't be thinking about symptoms as the way to differentiate between these conditions and to understand the differences between them. One thing it does talk about is the affected vessel, which is the paramedian branches of the anterior spinal artery. And I can't necessarily actually remember exactly where that is, so I'm just going to search that up. So having a look at this image, it kind of gives me an idea of maybe I can branch or think about these stroke syndromes in terms of their arteries and where those arteries actually are in the brain and the body. So what I kind of know already is that the MCA, ACA, and PCA are all kind of in the brain, whereas it seems that there are other stroke syndromes that are quite a bit further down. So one thing I might try to do now is to try and think about the stroke syndromes in terms of their vessels and where the blockage might occur, and perhaps try to understand the symptoms through that. So I've had a look at medial medullary and I just have a broad idea of where it kind of is, the anterior spinal artery or the vertebral, and I'm just seeing lateral medullary and it's saying it's the pica here. And I also saw that from my keywords that a pica stroke was above as well. So I'll just have a look at this and see what it said above. Okay, so it says above that pica also is to do with lateral medullary syndrome. So I can probably, just to make my life easier, move some of these keywords in a way that makes a bit more sense. And in terms of medial medullary syndrome, I can probably put that under anterior spinal artery. Because now I'm starting to think of things in terms of vessels. At the moment, I haven't really written that much down, but in my head, I am thinking about possibly framing this mind map in terms of this diagram here, and perhaps the way that the artery progresses up and understanding the strokes through that. So I might actually start by drawing a little bit of that. And as I'm drawing this, I'm noticing that, oh, okay, there is a thing here, which is the posterior inferior cerebellar artery. So I'm going to think about that as well, and perhaps draw that onto my mind map. And just as I did that, I realized just kind of something obvious, which is that the midline is kind of here, and the anterior spinal leads to the medial medullary stroke syndrome, whereas the pica stroke leads to lateral medullary, and lateral is lateral and medial is medial. So perhaps that's one way that I can think about it, which just makes sense, I guess. That kind of reminds me that I'm not entirely sure about the anatomy in that sort of region, so I'm just going to search up medulla. So then this is starting to make a little bit more sense to me. I can see how things might relate together in the terms of the anatomy of the structures there. So I think again, I might actually rearrange my keywords again to kind of think about it maybe in terms of the medulla. And I'm just noticing that I might be getting a little bit too sucked into just this area. So I'm going to kind of zoom out and try to think about other things as well. One of the things I noticed that I had a look at here was lacunar strokes. And I've never really understood what lacunar strokes are, or like what they actually refer to. So I'll have a read about that now. The other thing I noticed is that as I was collecting keywords, I noticed that it says the lenticular striate arteries refer to lacunar syndromes. So I'll just have a look at that as well in terms of my anatomical diagram. So it seems like it's a branch of the MCA, which would tell me that it's kind of up here in the brain. As I'm reading about these just lacunar strokes in general though, one thing that's coming to mind is that it doesn't really seem, in my head, it doesn't really make sense that of these small lenticular striate arteries, all causing these possible different stroke syndromes. So I wonder if that's actually the only artery that kind of causes these strokes, or if there can be other arteries that cause lacunar strokes. So for this, I'll ask ChatGPT. So then this tells me, okay, lacunar strokes aren't necessarily just caused by infarction of branches of the MCA. It can actually be anything. So this is actually not right. And I guess the way that the information in AMBOSS has been presented maybe would make you think that that was the case when perhaps it's not. So when I think about this now, I'm just like really confused about what a lacunar stroke actually is. So one of the things I like to do is just ask where the name came from. And that's actually really interesting what I've been told. So that it comes from the idea of a small cavity. So it's from a small artery causing a cavity in the brain. So then that kind of makes me think, okay, maybe in the brain, I can think about the strokes in terms of big arteries and the small arteries. So maybe I can think about it like that. So I'm kind of simplifying the topic down a little bit more, and I might just reflect that in my keywords as well. So I've kind of got all of this stuff here already, but I just want to make sure that the stuff in the middle here actually still also connects. So I might move on to just thinking about that for now, because I have a kind of idea of the stuff in the brain and the stuff at the bottom. So I want to fix the stuff in the middle. So now I might as well think a little bit about the other stroke syndromes, and I might just continue looking from this diagram and just moving up. So I can see the next thing is kind of the anterior inferior cerebellar artery. So I'll just draw that on and see how we go. Actually think a little bit about it, and let's have a read about what stroke syndrome it's related to. So let's go. Lateral pontine syndrome. And I'm not even going to really, to be honest, look too much about what it causes, but I can see that reminds me of this kind of diagram, and it's telling me maybe, okay, we can think about this in terms of the pons. So this whole region is the pons. So now I might think about some of the other pontine syndromes, because I think they're all together. Yeah, they're all here. So ventral pontine syndrome, this is the basilar artery. And I remember that the basilar artery is kind of this one here. And I think I've been thinking in terms of position, but honestly, I don't really know what ventral means. So I'll search that up. Okay, so it seems to mean kind of front, which makes sense. In terms of ventral and dorsal, that makes sense. But now I'm kind of thinking about why is that ventral? And I also like to think about the other pontine syndromes. So there's inferior medial and locked-in syndrome. So I'll think about the paramedian branches and what that means. Okay, so the pontine arteries are the general term for these arteries that come off the basilar artery, but the paramedian are specific ones. Okay, so this is sort of making sense, a little bit more sense now, and I'm starting to get a better idea of the bigger picture as I'm going. And the one thing that I am kind of feeling at the moment is that it seems like this section is basically all the medulla, and then that kind of connects to the pons, and then that kind of seems to, I'll move this up, move on to the midbrain, and then we get to the kind of brain itself, or the cerebrum. So as I'm kind of thinking about it more, my keywords are getting a little bit more organized as well. And I'm not necessarily 100% sure that this is what I'll finish up with, but I'm just picking this as a kind of hypothesis for what I want to work with at the moment. So now let's look at the midbrain, which is basically most of the stuff that seems to be left. So we've covered that. We've also covered this. Looking at the midbrain, it's telling me that most of the affected vessel is the branches of the posterior PCA, which I'm understanding to be up here in the brain. I'm going to have a look at this as well. And I can kind of see how it would affect the midbrain as well, because it's just going a little bit down, or I guess it's the most posterior of the major cerebral arteries. So this is kind of one area where I feel like the actual arteries aren't going to help me understand the differences between these syndromes that much. But one thing I have been thinking about so far has been the kind of location in terms of the, I guess, X and Y axis of the spinal cord. So that might be one way I can look at these as well. So I'm going to have a look at this video about midbrain syndromes, and we'll see if it can simplify it down for me. So there's a lot of stuff about the anatomy which I don't want to necessarily memorize all of it, but I can maybe see how it would be divided. And so, okay, so this actually separates these midbrain syndromes into a pretty easy to understand thing. We've already talked about this idea of ventral and dorsal in terms of pontine. So I might actually use this as a framework to understand the midbrain syndromes, which seems to make quite a bit of sense. So he's talked about the basis and tegmentum here and the tectum here. And so I might actually just draw this on as well. And the other thing I just did is just drawing an arrow from PCA to this section of the midbrain, which will perhaps help me understand that it's a PCA that's involved in a lot of these infarcts. So since I'm not trying to like get into this really deeply, I'm not going to look too much into each of these, but I'm just going to keep watching the video to see what he says about it. Okay, so it actually makes me understand the midbrain syndromes quite a lot more, which is quite helpful. And I know that perhaps if I want to go into the details, I probably can look at it anatomically, which is nice. I'm going to reflect that in my keywords as well. So now I've actually basically gone through essentially all of the keywords that I had at the beginning, which was quite a lot and quite overwhelming. And now I've kind of simplified it down into a relatively understandable format. Now the only two main keywords I have left are this about the extracranial arteries and other regions. So I'll have a look at that. So one of these already include the vertebral and anterior spinal. And just looking at this here, the vertebral artery I understand is this one here. So looking at this, it says lateral medullary, medial medullary, and neck pain, and signs of PCA infarct. So I'm not exactly sure about this part, but these two parts actually make a lot of sense because medial medullary comes from anterior spinal and pica comes from, they both come from the vertebral artery. So it would actually make sense that this leads to those two. In terms of internal carotid and common carotid, these two aren't really as related. Perhaps they're just below here in terms of extracranial arteries. But for now, I think I actually might just skip them and not include them in this because I want to just focus on the ones that I've got here in my framework so far. And then there's the other regions of the brain, which are here. And I can already immediately kind of see that this and the small artery infarcts might actually be quite related in terms of how we think about the details and memorizing the content that's actually within it. And now I promised that I would tell you how I would encode details through this process. So I'm not going to be able to do it for the entire mind map right now because that would take some time, but I think as I went on, I would look at all of these things, all of the details that I wanted to know for these different stroke syndromes and compare them as well. But for now, I'm just going to zoom into one specific area, and I feel like maybe doing the midbrain would be cheating because we have that video that laid it out really nicely for us. So let's look at the medulla, and we'll talk a little bit about the details here. So the first thing that I'm kind of curious about is because we had this set out so nicely in the medulla, the midbrain, I'd like to think about how the spinal anatomy would help us understand perhaps the details of a pica stroke versus an anterior spinal stroke. So for this, looking at the specific details for this, we've got these different symptoms that come up. So for medial medullary, we've got ipsilateral tongue palsy, contralateral hemiparesis, and decrease in proprioception. So if I just read that on my own, like it doesn't really mean much to me. And even if I was to make a flashcard for this, like what are the symptoms of medial medullary syndrome? Eventually maybe you would get that, but I'd probably have to do that flashcard a lot of times. So I want to kind of think about why does that happen? And it kind of is telling me about the affected structures. So what I might do is look at medullary syndrome. So I might even just search that up on YouTube. So this video is actually talking about the rule of 4, and this is something that I actually remember from pre-clin, although I can't necessarily remember the details, but I feel like this might actually be quite helpful for understanding these stroke syndromes. So as I'm watching this, it actually raises an important point, which is that this is far too overwhelming and I cannot absorb all of this at once. So as I'm doing this, I'm kind of thinking to myself, I'm not trying to remember this. I just need to know what's relevant to medial medullary syndrome, which is what I'm trying to learn at the moment. So now I'm able to correlate what the affected structures are to this diagram here. And that actually makes a lot more sense. So we've got the hypoglossal nerve, which is kind of in the middle here. We've got the corticospinal tract, which actually crosses at the level of the medulla. And then we've got the medial lemniscus, which also does the same. So now I can see that the medial medullary syndrome is going to involve basically all of these structures here. And then that actually makes a lot of sense as to why there is basically tongue deviation, contralateral hemiparesis, and contralateral proprioception loss. Okay, so that's actually an example of how I would understand intuitively the details relating to medial medullary syndrome. And I could do a very similar thing for lateral medullary syndrome and basically all of the syndromes here. But the important thing about this is that it is actually true that I may not necessarily, once I've gone through all of these things, remember these specific details. And so this is actually something that I might decide to make a flashcard about. So I might make a flashcard that says, what are the symptoms of medial medullary syndrome? But that actually is a little bit harder to do because there's 3 things that I have to remember. And the thing is, in medicine, you can be asked things in multiple different ways. So one way that I could be tested is, yes, what are the symptoms of medial medullary syndrome? And then I might have to list those 3 things. But what's more likely actually is that I'd be given a patient scenario where someone has contralateral proprioception loss, contralateral hemiparesis, and ipsilateral tongue weakness, and then I'd be required to make the diagnosis from there in terms of the artery that's affected or what syndrome it is. So in terms of my card, I might actually do my card the opposite way around, where I have these 3 things in my queue, and then I have to remember medial medullary syndrome, as opposed to the other way around. And then in terms of remembering in terms of medial medullary is these 3 things, then that would probably be better done through a big picture, intuitive memory kind of thing. So maybe I would practice teaching this concept to someone so that it made sense to them. Or I just do a mind map brain dump where I try to recreate this mind map from scratch and improve it. So this mind map isn't finished by any means, but I feel like I've been able to gain a pretty comprehensive, big picture understanding of the stroke syndromes. And I also have a very good starting point from which I could go to learn all of the details that I need. The thing that I really, really hope this has kind of illustrated is that flashcards will never be able to recreate this type of knowledge because you're only ever going to be going from one thing to the next. So for example, what are the symptoms of medial medullary? These 3 things. And it's true that if you spam those flashcards and do them again and again and again, you might be able to finally remember it and get that question right. But this type of knowledge actually helps you stop yourself from getting confused. And it also means that that information is much more fluid. You can use it in both directions. The other thing is I'm not necessarily not going to make a flashcard for this. I can make a flashcard for this and I'll be able to remember that flashcard much easier had I not done this. And this actually didn't take much time at all. If you've enjoyed this video, you might also enjoy this one about how I studied 5 hours a week in the hardest year of medical school.